Wow, what a Sunday afternoon learning endometriosis. This is amazing. It's a joy because endometriosis is a disease that I'm passionate about. I personally had it, and I was diagnosed back when I was 25 years old during residency. It was very tough. I had a dermoid cyst, and always have pain during periods, but you know what? I toughed it out, like medical school, MCAT, pre-med. So you tough it out, the period and the menstruation. And then one day, I just felt a little bit uneasy. I wanted an ultrasound, and they found a dermoid cyst. So I never knew I had endometriosis even before the surgery. And when you're a medical student, you think everything is cancer because you see all this patient on the ward, and you're like, what? What cyst? A dermoid cyst actually is a benign cyst that grows on the ovary, but you never know what they are. So I got scared. I'm like, Mom, I think I have cancer in my ovary. I need a surgery to take it out. And then when they went in, not only they took out the dermoid cyst is a benign tumor, so it's not cancer, but they found stage 2 endometriosis, which means the tissue spreading in the bowels and the uterus. And I chose, since I'm in the field, I actually in residency, in OB/GYN residency, we do lots of surgeries, and we know the surgeons, we know who you like, who are the doctors, so I chose the surgeon I love, Dr. Janelle at Brigham, and she operated, and when I woke up, my whole life was just being a doctor. I never thought of getting married or have a baby, so then when I woke up, she said, Janelle, you had to have a baby. I said, what? What do you mean? I'm studying, I only get, I don't know, I guess if inflation sounds really bad, but it's like $3,000-$4,000 during residency. You cannot pay rent. I'm like, what, have a baby? Where's my? And luckily, I met my husband during college, so I did have a partner back then. So I said, okay, I would think about this. So it did hurry me with my fertility plans. I just want to be an REI doctor, like it's on my wall. Straight A's, REI, yeah, it's a little bit crazy, but I was very, very goal-driven, going to medical school and go on to residency, the best program, and move on. But then that really gave me some empowerment and really awakening me about the disease. I was lucky. I had a partner. The plan was, to get married and a baby, but not so easy for many of my patients who have those crossroads. So I thought to begin this lecture, I want to share you my personal journey and story because I know so many of my patients are going through it at different stages of their life. I do feel women are very different in their 20s, 30s, 40s, biologically with the ovaries, different from men. I always say that. Guys are very different. Career-wise, we are similar. So I'm looking at my male colleague who is standing there operating. They can have the babies at 30. They can have the babies at later on in their 30s. So some of you know, the residencies is long. Medical school is long. The training together is like 12 years from all the way to finish. So it's like back, until you're in your 30s. So it's not easy for some career move, not only just to treat endometriosis, which is a very painful disease where you are grueling through it, trying to accelerate and ascend in your career. But at the same time, you also have to think about, oh my God, do I want a child? Is it right? Having a baby is the right for every woman, like Lydia was saying, which share a very amazing story to be awakened and able to be empowered and ask the authority, hey guys, look at me. Maybe that's not, just pain is not acceptable for me. I should not live like this every month of my life. So I was also very touched by the patient's story. Okay, so today I just wanted to talk about endometriosis and road to fertility, and some of the biggest question for myself, who are now on the other side taking care of patients of endometriosis, and some of the what the thinking I have to think about when patient does come to me. So sorry. Is it just forward? Let's see. Oh, the green one. Sorry. Thank you. The big one. Oh, above. Thank you. Oh, yeah, disclosure, none. I'm the medical director and the co-founder of Generation X Fertility. but no other companies. So this very standard graph of causes of infertility, and I think Lydia also mentioned this, which is about the unexplained infertility. So I don't know if the diagram is a little bit fuzzy. I'm going to read some of the numbers. So for couples who come in for infertility, about 35% of them have male problems. 35% of them have tubal and pelvic pathology issues, which including endometriosis. And then for unexplained fertility is around 10%. And then ovulation dysfunction, aging, or anything with the ovaries not able to ovulate, so that is about 15%. I get very excited and also with the patients and a little bit vulnerable, when the patient comes to your office and asking for an explanation why she's not getting pregnant, then I say, hey, you belong to unexplained infertility. That is a very humble experience because she's coming here for you to explain something. You tell her this is unexplained infertility. It's really ironic sometimes. But that category, that's what Lydia was trying to say, may have patient with endometriosis. And this becomes very tricky. How do you diagnose that? How do you put the patient in the category of unexplained fertility, but to the pelvic and tubal pathology? So this is something we will talk about as the patient comes to me with infertility and what are the things and thinking that I have. So 30 to 50% of patients with infertility have endometriosis, and 10% of patients in the world has endometriosis. So it is a disease that is it does affect patients. I did a great Instagram live, I think, with Dr. Haas, and we had lots of questions. And the poor patients are so savvy. I know they're from EndoFund, from my patient. They were asking all these questions before even the Instagram started. They asked, is IVF the only option for women with endometriosis? I have 2 chocolate cysts in my ovary. Should I do surgery? Would excision cause diminished ovarian reserve? Why would I have endometriosis if I don't have symptoms? Does endometriosis removal help with IVF outcome? What are tests for endometriosis? And how come there are different approaches for endometriosis? So we're going to try to cover all these questions in my lecture, and I saw your beautiful agenda from Tamara Shashkin, whole weekend of the symposium. Some of them has been answered already, I know, from other lectures. So I'm going to just go through some very simple and the thinking that I go through with my patients as they come to me with some of these questions. So what to do and how to treat. So this is a little bit different from some patients just coming in for pelvic pain. You have to understand these patients are really trying to just get pregnant and have a baby when they come to my office. So pain is secondary to them. And usually they don't mention about their pain. They just say, Dr. Lu, give me a baby, get me pregnant. So surgery is not on the top of their mind. They just want to have a baby. They just want to get pregnant. The idea is that we, as doctors, we always go to the chief complaint. We start always from there. Then we go. Like, I have leg pain. Then you go, why do you have a leg pain? I have stomach pain. Then you go to stomach pain. So you always go through why patient come to your office. And majority of patients go to a fertility center is want to have a baby. And so so I always look at what is the presenting symptoms, because that would differentiate suddenly how I think about this patient. And presenting symptoms is, so chief complaint is I want to get pregnant. Then I ask, what is your presenting symptoms? Like, do you have other presenting symptoms? I was like, well, what else do you have except that you want to get pregnant? How are your cycles? Do you have pain during period? So those are the things that elicit it. The diagnostic tool usually is physical exam, ultrasound, MRI, laparoscopy, which went through by some of the doctors from yesterday, how to diagnose endometriosis. But endometriosis can be silent. Endometriosis can be, you can still have endometriosis with a great physical exam, with no ultrasound of any endometriotic cysts. MRI doesn't show any highlighted lesions. You can still have endometriosis. So any non-invasive, except the laparoscopy, which is a surgical intervention, any non-invasive tools doesn't mean, if this is all negative, doesn't mean you don't have endometriosis. So then this is where my professor, when I was at Yale Medical School, they always say, Janelle, we have lots of fancy tests and ultrasound and everything out there, but at the end, the best thing a doctor can do for a patient is history, history, history. Taking a great history is so, so, so important. And quite honestly, I see a patient in my room, we take a history, it usually diagnosis is about 70 to 80% of the time. I'm very accurate with my diagnosis, just taking a history. I can do ultrasound, I can do other evaluation to confirm. But taking a great history, asking and be open about endometriosis and learning about it is so important to a patient, and empower them. Because some patients, they are so absorbed of having a baby or the fertility, they may say, oh, Dr. Luke, I've been having pain for 20 years. It's so great. I just take 2 Tylenol. It was great. They may have lost because they're sucking it up. They don't want this to be intervened with their career or their life. They may not see as a symptom. So I have to elicit. I have to bring it out from them because it is not easy sometimes because patients' priority was not because of pain. That's why they come to you. So taking a great history becomes so important. Why I'm start to go into medical treatment, and I know the lecture before me, they went through a lot of lots of this great and medical treatment, and so endometriosis treatment for when you're trying to seek a baby is very limited because all medical treatment is anti-fertility. You cannot get pregnant on this medical treatment. So you cannot say, oh, let's take some birth control pill. Then you will be great to get pregnant. No, you can't because of birth control pill. Take some Lupron. No, you can't. You cannot get pregnant if you're not cycling. So medical treatment is not a choice for endometriosis when patients are seeking for fertility. So then this remained then surgery. So after I elicit a question to a patient, this is where the trick comes in. Hey, so-and-so, you're in pain. I was like, you may or may not have endometriosis. And majority of patients will be like, oh, really? I said, how do you diagnose it, Dr. Luke? How do you confirm that? I said, I cannot confirm that. However, the way the gold standard of endometriosis diagnosis is usually a laparoscopy, which is a surgery. And majority of my patients do not like to go to surgery as the first intervention. And this becomes really tricky for us as infertility doctors because pain is not that bad. They just want a baby, and you are telling them you need to do a surgery in the operating room to diagnose endometriosis. Sometimes they're hesitant. So now how do you educate these patients? And what do you tell them? Now, I know Dr. Shashkin in the audience would say, well, Dr. Luke, surgery can help fertility. That is why we do surgery. Absolutely. And this is some of the things that we are and forced to do. But then that's why in the couple of slides at the end of the lecture, I also talk about some of the non-invasive testing as also how to take care of some patient who is unwilling to do surgery. So how does surgery able to improve fertility? Actually, many studies has discovered for stage 1 and stage 2, I know Dr. Shashkin also talked about yesterday at the lecture, surgery improved tremendously in the fertility for patients of endometriosis. IVF may not be the first treatment they go to. They go to surgery first because it can decrease the inflammation environment in the belly, improve quality of the eggs, increase treatment of the improvement of movement of the cilia, and resection of the scar tissue. It decreases any oxidative stress. So it has to multiple organs. So it is not a bad thing. I had a patient with severe endometriosis. She did not have the financial means to do IVF, so I sent her to her surgeon, who is an endometriosis specialist, and her tube was basically twisted around the ovary. And I want to show you this diagram is to show you that how the gametes migrate to the uterus. So when the patient is getting resection of scar tissue, that can also help with the movement of the from the ovary to the uterus. So it frees her ovary, frees her tube, and she got pregnant after 3 months of time intercourse and after surgery. Second thing we do for treatment of for endometriosis is IVF. So there were also papers coming out, and I know when you have a hammer, everything's a nail. When you have, yes, that's right. I was just like, the nail. So I'm an IVF doctor. So the first thing patients come in is, and I told you, the majority of them do not want to go to surgery. They just want a baby. So they would ask me, Dr. Luke, can you have me do a IVF? I really just retrieve eggs, make an embryo. I have patients even have chocolate cysts inside the MRI, see the endometriosis. I told them you have endometriosis. They say, no surgery, Dr. Luke. So we did mild IVF where we do letrozole, and this is some of the things I feel passionate about, mild IVF. What we do is that we give a pill, which is the aromatase inhibitor, with decreases the estrogen exposure for the patient. Then we stimulate them with low dose of injections of FSH and hope to get good number of eggs. Some of this patient, when they do have endometriosis or has surgery in the past, some of them may have diminished ovarian reserve. And so the egg quantity is not a lot already. By using this kind of protocol, I do have to adjust the FSH dosage really individualized from day to day to try to maximize the ovarian potential. And so we give letrozole in conjunction with the shots. The way he is very general presented, sometimes I do give shots in the middle, means I don't stimulate them at the beginning. I usually do letrozole first, then stimulate. It really depends on how the ovary is waking up during the cycle. So one of the questions I didn't address in here, that's why I brought back the slide, is what if the patient have chocolate cysts in the ovaries? One of my friend who gave me this picture with the chocolate cysts and the endometriosis, my colleague, Dr. Farrell. And so what to do with that surgery sorry, let me go. Yeah. So what to do with the chocolate cysts. And so one of the things I was just showing you the picture. If you do have chocolate cysts, the idea is what's the size and is it bothering to the patient. And for me, when patients have 1 or 2 centimeter chocolate cysts, sometimes they do not want to remove the chocolate cyst because it's small, it's not bothering them. When it is bigger than or bothering the patient, like pain is the bigger driver for surgery for me to tell patients, especially when patient, again, is not seeking for surgery. They're just here for a baby. For 2 centimeter cysts or smaller cysts, why IVF doctors are like, oh, don't do the surgery if you don't need to, because the ovary is wrapping around the cyst. I don't know, in the previous picture that I was just showing you. And when that happens, when you try to cut the cyst, it can sometimes damage the ovarian epithelium. And as a result, diminished ovarian reserve, I have seen them after multiple surgeries or multiple chocolate cyst resection, it does diminish the ovarian reserve. So that is why we don't usually promote when it's smaller cysts or it's not bothering patient to remove the surgery, to do surgery first. So then the next talk is, which is very controversial, which I mentioned with Dr. Haas in our Instagram live, is it possible to diagnose and treat endometriosis without surgery? So I am a very old school. I know I don't know. I've been practicing now 12 years. So 15 years ago, when I was 17 years ago, when I was in medical school, I was never learned non-invasive testing. Gold standard is always laparoscopy. 2-3 years ago, a new test came out called Receptiva. Where involved with biopsying the uterus, means they take a little sample of the uterus, and then they try to find a marker called BCL6. I was with Dr. Hugh Taylor at Yale Medical School. I was one of those medical students who collect this tissue in the operating room for all patients with endometriosis or no endometriosis who sign up for the study. And we will be checking, we'll bring the tissue from the surgery, I remember, suite, back to the Yale research lab, and then we just trying to find a marker to see if there's any marker we can check for endometriosis. So this was the marker, and there are a couple of them. So this got famous, which is called BCL6 positive patients in the Receptiva study. So then my patient, obviously, the study went very public. Patients start to ask me, because now they say, Dr. Luke, my embryo didn't implant. Check, do you now need to do surgery to see if I have endometriosis? They have no pain. Now it's ironic, these are no pain patients, and I told you endometriosis can be silent. Now they come to me with a presentation with embryo not implanting. So that is tricky, because now there's not in pain, so you don't immediately to do anything. But it's because of embryo not implanting, they're asking me, does she need surgery? And it becomes very interesting is because last 10 years, I know some of you who are in the IVF world may also know, we start to screen embryos to know if the embryo are genetically normal or not. So in the past, 10, maybe 12 years before the last decade, we usually cannot test embryo. So when the embryo went into the uterus, I put it back into the uterus and it's not implanted, us doctors, a very easy job. We just say, oh, don't worry, it was just a bad embryo. So you didn't implant. So let's do more IVF. We need to get better embryos. So then it will get in and stick. Then this PGTA testing came out, which is a genetic screening of the embryos, which supposedly is that to screen if there's a Down syndrome or anything genetically wrong with the embryo. And if it is normal, it should stick. That is the theory. So then the test came very famous. I remember when I first came practice the first year. Everyone, I'm like, yes, do the screen. Who doesn't want to predict a boy, girl, normal? You tell them it's high success rate when you screen the embryo. So I did all that. Then after a couple of cycles, then you start to have patients didn't have a great normal embryo, but didn't stick. Now, the patient come back to your office and say, Dr. Luke, you made me this embryo and it didn't stick. So what's wrong with me? So then, this very smart, the researchers in the last 10 years, and we discovered, wait, endometriosis, right? Can cause this bad implantation. But no one really wants surgery. Again, these patients do not usually have pain. They just want to get a baby. So now they came in and say, Dr. Luke, I saw this test. So this test developed in the last 5 years. And I got this on my desk. And they say, Dr. Luke, I want to do Receptiva. I said, wow, okay, let's do that. And if you do a biopsy, you will know if I have endometriosis or not. And I was so hesitant to do it because I told you, I learned the old way. The gold standard is laparoscopy. Now you're asking me to do some new test 3 years ago, do some biopsy, and some marker goes up. And now I'm saying, you know what? The marker went up, so you need to go for surgery now. First of all, it's a big deal telling a patient to go for surgery who have no pain and never asked me for surgery and just coming in to ask me to implant an embryo. So it was become a very difficult choice for me in some ways. So I waited a little bit. So I was more skeptical kind of a doctor. So 1 year later, however, more study came out by 5 big institutions and say, wait, we found a treatment. The treatment is, if you give the patient Lupron for 3 months, it will improve success rate by 15 to 20%. Or surgery that will improve by 10%. So suddenly, I have this kind of feedback from social media, from the study. Then this test becomes more valid to me because now I can give patient the choice of either doing surgery or Lupron. It's still a big thing. Lupron is a hormone medication, which is described by the previous speaker. It shuts down the woman's menstrual cycle, One more time, this patient's here try to cycle and have a baby and have sex. Now you're shutting the biological clock for 3 months and say, wait, get some treatment, and we will give you placing an embryo. So this test just came in the last 2 to 3 years and becomes still many places are redoing some of the research and data. I know Columbia, Zeph Williams is my friend and also IVF director there, and they are doing studies and looking at endometriosis and really have one-to-one correlation. Still try to discover the validity of this test. But that is right now the only test I know where we will do something or not do something from a non-invasive way from endometriosis. Okay, I'm pretty good. Oh, yes, I think there's some questions, Dr. Haas. Yes.
Thank you for your presentation, Amanda here. So I have done 2 laparoscopics, went into 5 rounds of IVF, and then 5 transfers, 2 miscarriages, 3 that didn't stick. But I have genetically tested embryos that are normal. And so what would you recommend as kind of a next step? Would it be and I've done the ERA and some others, but.
I know. Thank you for sharing your story. I know it's hard. The process so grueling and hard. So, as some of you may know, I know endometriosis, the etiology of it, have lots of causes, and thank you, Amanda, for sharing this story. There's lots of inflammation in the possible. So endometriosis, one of the theories that there's Samson 3 back in 1926, which is retrograde menstruation. And one of the theories that if there's some dysregulation of immune system in the belly, that can cause us high inflammation. So when patients are having this discussion with me, and this is a day-to-day discussion that I have with my patients, so I just want you to know. Generations Next, when this first started, of course, we don't have the big institutions name all around the city. So many of our patients, when they failed and they come to our office, and we had to think outside the box to treat patients. So thank you for sharing. So ectopics, just listening to your history, that I know there's lots of inflammation already in the belly. There are 2 things, and then there's also the embryo screening normal. So I'm going to discuss 2 things. 1 is the environment, 2, embryos. The environment. So the environment, I know surgeries, we talk about exploratory laparoscopy. It's so funny, I don't know how Dr. Shashkin does it, but I used to learn from some of the endosurgery, they sometimes wash the belly from the inflammation. They would just kind of flush the belly and get the fluid out. I know, Dr. Shashkin's like, So there's the inflammation, kind of a treatment of the belly. Lupron, there's another treatment that can think about like how to shut down the estrogens, the feeding of the endometriosis. The second thing is about embryos. This is really, really hard for me to tell my patients because I do also have normal embryo fail for implantation or miscarriage, repeated miscarriage, 2 or 3, and the 4th stock. So for stories like this, and also patients I've seen have multiple means, they do GC, they do many things, and still have a miscarriage. So then I want to remind all of us what a screened normal embryo means. A screened normal embryo, all it means is that it's a 4-6 chromosome. And sometimes they cannot screen triploidy, by the way. So if there's a repeated set, the machine miss it. Okay, so just be mindful. Error rate is still 3%, but I'm not trying to say all your embryos are in the 3%. I'm trying to say is that there are other things that genetics are not being screened for, such as placental cells, implantation, through factor derm, how healthy are these cells. So as my career is growing and watching the failure of screened normal embryo not being sick or having issues like this, I do reinvestigate the environment with the patient. With Dr. Sheshkin, with all the endometriosis experts, I reinvestigate the belly. Yes, we do sometimes have to transfer sometimes 2 embryos in, because that means not all the embryo, even though they're screened normal, have good placenta cells. So let's say my patient had 5 normal embryos, it already failed 2. I may have to, the 3rd transfer, not to went through the emotional trauma is horrible for these patients, and to just put 2 in, so they don't have to go 2 more separate transfer to get to the right one. So those are some of my suggestions. Oh, yes.
I feel very ignorant for asking this question, but for IVF, how many rounds of IVF is recommended? Or do most people just have 1? It's very expensive to do. And then how many eggs? Like, when do you know you need to do another? I guess, I don't know if it's a term is
No,
round
don't
of
worry
IVF.
about it. That's a great question.
I've been concentrating on other things.
Yes, no. That's a great question. So,
Thank
average patients have about, let's say a patient, so this is all depends on age. Go back to the age factor. So in the patients with in the 30s, they usually can get over maybe the range can be huge. So yes, there are low normal number of eggs, but like let's say 5 to 15 eggs. Usually we'll get like 3 to 6 blastocysts. Means the end stage of the embryo, and then screen-wise, half of them will be normal for a patient who is between 30 and 35, and then it's like 10% decrease as the age goes on. So for patients who are under the age of 35, if they have a good quantity of eggs and they're making good number of embryos, they usually need 1 IVF. They don't need more. Now, I told you Generation X was started when there are lots of giants around me. And what kind of patients come in? I don't usually get 10, 15 eggs. We usually get 2 to 3 eggs, 1, 2, 3, or 4. So these are usually patients with diminished ovarian reserve. I'm passionate about endometriosis, but I'm very, very passionate about a diminished ovarian reserve. So this patient only have 1 or 2 eggs. Some of them are older, some of them younger. But what we do is that we keep on retrieving the eggs. Now, the younger you are, even though you get 2 eggs, please don't cry. Usually you will have 1 good embryo. So it doesn't matter, there's only 2 eggs. So quantity never justify fertility potential. It's the age, and how long you have been trying to get pregnant. So 1, 2, or 3. So for those patients, some of them we do need repetitive egg retrieval to bank enough for embryos, because usually they want to get pregnant, breastfeeding 3 years later, they want to make sure, because now the ovary is more decreased in terms of their reserve. So then they will need to use the embryo that they banked 3 years ago and be their second baby. So that is when people will do multiple IVF cycles. Oh, this question.
Hi, Dr. Luke. How are you?
Hi.
I was just wondering if there are women who are in their early 20s and they've been diagnosed with endometriosis, 20s. Do you recommend these women with endometriosis to freeze their egg early? And during that time, when these women are going to freeze their eggs early, the process to actually give them different types of hormones to freeze these eggs, would it make endometriosis worse? It's just understanding the irony of this.
I was going to address this. This is such a great question. You guys are so smart. Oh my God, these are tough questions also. So I was just talking to the patient and patient's father. So usually when patients come in the young 20s, they come with their parents. They just finished college, they're in pain, they have endometriosis. They come to ask me the exact question the way you worded it and say, Dr. Luke, I'm scared, I want babies, I'm in pain, I have endometriosis. And this is a very knowledgeable college student, and she was asking me, and also talking to her dad by her side, I want to freeze my eggs. And then the daddy asked me those questions. Is it worth it? Is it very expensive? Why am I doing this now for my daughter? And I was like, okay. So here we go. So So first of all, why is this patient no stress endometriosis? Usually when patients so young coming to BS, there's pain. And as a woman, we should never live this way. Pain is not normal. We should not say it's normal. It's okay, pain's okay. It's okay, I sweep, I wash the dishes, and I go home. I'm kidding. I tell that to my husband. But women should have their own empowerment and know, and it's not okay. Certain things is just not okay, and we should not live that way. So I usually just kind of think about it this way. You're just absolutely right. Every time you stimulate for egg freezing, you can invoke endometriosis. So this patient also thought about this, and the logic was this. She also had diminished ovarian reserve. That's how she came to my office. And she has pain. She knew. And she read about endometriosis, and she actually went to see an endometriosis surgeon before seeing me. So the discussion went out like this. If you have, we actually went ahead and did 2 egg retrievals to get her eggs because she's young, knowing that endometriosis flare. So I talked to endometriosis surgeon, knowing that I did give that letrozole protocol, which is turning down her estrogen and kind of the same. So one stone hits 2 birds. One is to stimulate her ovaries, and one way is also to suppress the estrogen. So we stimulate her with letrozole, with FSH. And also to cut down the cost of IVF because letrozole is much cheaper than FSH medication. And we do encourage her to do that, and she wanted it. She wanted egg freezing, and she said, Dr. Luke, and told Daddy next to her, I'm not going to have a baby until 35. Like, she was very determined. She knows her path. She knows her career. She's a photographer. She's going to travel. But I want to have a kid. And as a result, I want to do my egg freezing. So we did the 2 egg freezing, and now she's going through surgery, and we got pretty good. Her AMH was low, so this is funny. AMH is one of the marker looking at ovarian reserve, and that's really prompted her coming in. But when you're young, sometimes the AMH does not reflect totally the number of eggs that you have. With stimulation, I can get more. So age really beats fertility in many ways, or even fertility preservation. So the younger you come, it is an amazing story. Now, just want to reverse back when I would say don't do egg freezing. So I usually challenge my patients with egg freezing because I want them to be empowered. It's very expensive. You put your body through a lot. So I usually challenge them because I don't want to have regrets to do egg freezing. So I know today is not egg freezing talk, so I'm just going to say in what situation I would tell her not to do egg freezing. If she's planning, let's say I'm planning to have a baby in 1 year, or planning to go, then you don't need to because she's young. She's going to get pregnant if she's going to, have a family in 1 or 2 years. So some of the times I usually ask, why are you doing egg freezing? What is thinking? Then I would say yes, because she does not need, she can also do a surgery and have a family. She doesn't, but the reason why she was egg freezing was because she was knowing determinedly she's not having a child in her 20s, and she's going to have her career and so forth. So that's why egg freezing was in her agenda. Just want people to know. Great. Yes, I have to coach my daughter's basketball team. I used to play basketball in Hong Kong, so I have to coach a basketball team back in Scarsdale, so I have to go.
Thank you.
Sorry. Thank you.